Hi, my name is Chris Nortcliff. I am a GP, primarily down the corner from here in Kew, and I'm the Chief Clinical Information Officer of the Greater Manchester Primary Care Provider Board. CCIO makes it a little bit shorter. So I've got 7 minutes, so let's get on with it. What am I going to talk to you about? So I'm going to talk to you about, hopefully a little bit about large language models in general practice and finding the sweet spot. So, you know, where is the right place to use it? Where's the wrong place to use it? And I think this is really important because at the moment I often feel like this. When I open my email inbox and I've got a multitude of offers of the next big thing to change my life as a GP. And that's great in one sense, I suppose. It's great we've got such innovation, but what do we need to know to make the most of the technology that we're using? I obviously used AI to create this image. So AI and large language models have a multitude of ways that we can use them and find the benefit, but let's dig into that a little bit more. So there's a ton of, so we've already heard from Ben about triage, great use case. There's ambient voice technology, so ambient scribes, writing of referrals, writing of patient letters, writing of one of the policies that we all have to have in place in practice. All of these things are great options for using AI, or are they? So I'm going to focus a little bit on ambient voice technology. Why? Because it's something that's already prevalent out in the system. It's interesting that it's already prevalent because it's kind of emerged out of nowhere really, and if I go and ask colleagues in the NHSGM, like, where's using this technology? We can't tell them because it can be used on a web platform or it can be used on trials, and obviously these platforms offer free trials. So it's just here, and this worries me a little bit. Why does it worry me? I'll start with the question, is it always right to use this stuff? You know, what is the benefit that it's trying to bring? And I'm always cautious of when you see benefits listed in minutes that we've saved, because I'm more interested in quality, and are we improving the quality of what we're doing, or are we just trying to eat away at minutes? So personally, I would say I don't use an ambient scribe. Why? Because I'm very lucky to work in a practice that offers me 15-minute appointments, and I don't tend to run that late. If I am running late, it's not usually because of the task of writing my notes. I can't tell you the number of times when I've written a patient's notes and through writing them had then thought, I think differently about this now, picked up the phone and either asked another question to the patient or changed my management plan, or suddenly had, you know, one of those points where you think, I'm so stupid, why don't I think of that? The other thing is, does anyone, you know when you've written an email and it's one of those things that it's maybe slightly contentious what you're writing, or you don't want to upset someone, you think the tone of this is really important? That process of editing it normally takes me longer than actually writing it in the first place. And I think editing, for me, takes a higher cognitive burden than writing in the first place. So what are we actually trying to solve with them? So, I sound like I'm completely against ambient voice technology. I am not, but it's thinking about where do we use it. And it was really interesting to hear Ben talk about using ambient voice technology as an inclusivity enabler for the online consultation platforms that practices have to use. So I think that's a really, really good use case. But even when we're implementing that, we need to think about how do we do it safely. And Ben stole my thunder slightly about being able to reel off the DCV0129, DCV0160. Because I tell you, most GPs who are deploying this, or people working in practice, are completely unaware that those things exist, which is worrying. Particularly as CQC will be, have publicly said they will be including that in their inspections going forward. And it's not just AI, it's any health information technology. The other thing that really bothers me is that we always seem behind the curve and slow in the NHS. So I often use automation. So robotic process automation has been prevalent in the finance sector for 30 years. And now we're seeing lots of suppliers come and sell their wares using robotic process automation in general practice as an innovative new technology. It always seems that we're behind the curve. So what I'm looking to do in Greater Manchester is see how can we actually deploy stuff at pace and scale in a safe way. So we're going to test some ambient voice technology with some projects. I'm very careful about saying projects because it ain't proof of value, because that's been done already, it's already in use. They're not trials, but what I want to be able to test is how do we actually deploy something with a policy in place? How do we make sure that practices deploy along in keeping with the DCV 0160 clinical safety standard, which, for example, mandates that you must have an accredited clinical safety officer. So we've got 405 practices at present in Greater Manchester. We do not have 405 clinical safety officers, nor are we likely to have, because there is a cost associated with training people up to do those things. There is an ongoing monitoring. Hazard logs need to be not just done to deploy the technology, but to monitor it going forward. So we're looking at how we can test deploying something so that the ICB can be assured, the ICB, the Integrated Care Board, can be assured that this stuff is safe to use and they can get behind it. This all led from earlier this year, both the BMA and NHS England put out statements saying that ambient voice technology should not be used. You should halt your use of it unless you get assurance from your ICB. I think ICBs went, how do we give assurance to this? So that's what we're trying to do, is how do we keep up with change? Because inevitably there will be new AI use cases or new technology down the line. And I'm keen that we make our system work so that we can be responsive and ready for this change. So that's how we're testing that. The other thing I'm always keen that we do is do things in a standardised way. And as part of those projects to test our safe rollout and deployment of the ambient voice technology, I'm looking to make sure we have some standard operating procedures that go along with it. So certain things about how we use the technology worry me. I'll give you a few examples. You know, should we be using this technology on all consultations? Anyone who's ever consulted with a patient would tell you that a short transactional consultation is very different to a long, complex, for example, palliative care consultation. There are different things that come up. There's more weight on what's not said in some of those, and does that necessarily get picked up as by the ambient voice technology? We need to be vigilant. You need to check the human in the loop is the term used. So all of the outputs should be being checked every time. And I will tell you something, that human beings are terrible at being vigilant. So the automation bias will come in, that if it's looked perfect 19 times, the 20th time, I think at that point it very naturally would say, I'm sure it's fine. But in healthcare, you know, that one might be a really significant thing. I also have an issue with trainees using this. I sound like I have lots of issues, so I'm really As I mentioned before, editing is a skill. And to be an effective editor, I think you have to understand the process that you're editing. I remember as a trainee having very specific training from my trainer on how to document. You know, feeding back, oh, your notes are good here, they're about the right depth, you've caught all the salient points, all the salient negatives. Trainees, and I know there are trainees using these tools, are missing out on the opportunity to learn and refine those skills in order for them to be effective editors down the line. So in building those SOPs, these are things we need to do to make sure that we can maintain confidence in the technology and avoid those unintended consequences. So, finding the sweet spot. What I mean here about a sweet spot is AI is too valuable for us not to use, okay? And it is inevitable that it will be used. But we need to temper that with what are the right options, what are the right environments to use it in, when shouldn't we be using it? because it's not a panacea, it's not a cure for everything. And I think increasingly when you look in the world today, people are starting to think that maybe AI is a solution for everything. I said I wouldn't do this, but I will. I had a conversation immediately before coming here today, and it made me start to think about this. And we should be challenging this. So why we talk about human in the loop? The human needs to be in the loop for appraising the outputs of the AI. Well, why don't we flip that? Why don't we have AI in the loop for appraising what the humans do? And then we can maybe think about improving quality of what we do with that AI refinement, rather than being dependent on AI being the generative solution and us doing what we're actually poor at, which is being critical of that. So yeah, I am hugely excited by AI. I think it's something that we have to use. We have to do it at pace, at scale, but we have to do it carefully, and we have to do it in the right processes. So thank you.
Thank you for that presentation. I thought it's great, and particularly your closing point there about the flipping it on its head. I think ultimately in whatever area you're working in, there's a sign-off or a needed on all of this, and that's whether it's in law or in healthcare, and I think that's kind of where we're at, and certainly I see that. But the other perspective I wanted to provide was who's doing the kind of sense checking from the patient side as well, because you mentioned palliative care, but I'm thinking my area is mental health, and as you'll be aware, mental health conversations and consultations can end up being very huge, and I think there's a high level of subjectivity around sort of the patient voice, and I'm just wondering what your thoughts are around that and how that could be implemented.
So really interesting. So two thoughts on that particular. So I recently was speaking to a CCIO from a mental health trust who wasn't very keen on ambient voice technology. But he said that when it has been used, it really takes it's a different approach. So prepping for example, in the case of seeing a psychotic patient, some of the information recorded by an ambient voice technology might not be based in the real world. It may or may not be, and that's a real challenge. So they would be trained to prep the technology and say, give it context before a consultation and a debrief afterwards. That already makes that editing process more difficult. On the second point about patients reviewing it, so I think that's really important. I am a huge advocate for all patients having prospective record access enabled via the NHS app. Part of it is so that I think we need to change as clinicians to be viewing it as our records, and the stuff that I write down isn't mine, it's the patient's data. And I think we would be allowing and encouraging patients to read their record. I think is a really useful clinical tool in terms of me documenting management plans. It's really easy to forget loads of stuff that happens in the consultations, but it's there as a record. But challenge it. I'm sorry, that's not accurate. That's not what I meant. I think that those things are really, if we can change our protectiveness of that information and perceive it as a patient's data, not my data as a practitioner, then we can start having that conversation much more openly and correct things when they're erroneous.
Thanks for that. We've had 3 GPs talking today, nobody from secondary care. Clearly lots of this could cross over to secondary care. Are hospital consultants just a lot less innovative and doing things up, do you think?
Not at all. So actually I think it is deployed in lots of places, and it's in many ways it's easier to deploy in secondary care because they're essentially closed environments and they have governance which is easily structured. Primary care is completely different, general practice. So effectively we've got 405 independent businesses who, and this comes into it all the time, in terms of the ambient voice stuff, or any AI, I sit on an AI oversight group for the ICB, and we have to be very careful about what our purpose is, and it's there, we have described it as there to provide advice and help people understand the risks that they are facing with AI, because ultimately it's a GP practice's individual responsibility as a data controller to, they can deploy it, they can ignore us, it's up to them. There's loads of stuff going on in secondary care. Certainly, some of the big suppliers have recently done trials in A&E departments, and I can really see how that works. Wearing a microphone, so that things are recorded, then they go back and log into their base station, and all of a sudden they've got all the information there to review. Different context to how I would use it as a general practitioner, but certainly I know there's lots of clinics where they've trialled this and using this already. So the thing is, we already know about that because they're working in governance structures. We don't know about a lot of people using it in primary care, which is really where my interest comes into it, about helping us do it the right way.
I wondered about your experience about AI scribes, if you have used them, in terms of the scale of hallucinations and omissions that you see, because as someone who might be using it in the future in hospitals, in fact, that's my worry, but I haven't really understood how big of a problem that is.
So I don't use them. It's not a use case that I have felt I've needed to use in my practice. However, if you look at the albeit supplier published data, the hallucination rates are, less than 1%. So they're very low. I think that even with that, it just the fact that it can hallucinate really embeds the idea that you do need to be really, really vigilant. So there was a really well-publicised case earlier this year of it was a document processing AI tool. So it was auto-coding in a practice in London, and a fit and healthy 22-year-old got miscoded with diabetes following attendance to A&E with a broken arm. First he knew about it was when he got a phone call from the practice saying, "You're overdue your diabetes review." He was like, "When did I get diabetes?" And so, really harmful actually in terms of the stress that puts on someone who's works really hard to look after themselves, and in their 20s has suddenly found out that they think they've got diabetes. A huge time burden taken to correct that and understand what's happened. So even if they happen rarely, they can be hugely significant. So almost, in my mind, the fact that it ever happens doesn't negate the fact that every single instance you have to be hyper vigilant about checking, not just for individual hallucinations, but has it got the context right? Is this say what I want it to say?
I think that's a really interesting point, and I do completely understand that particular scenario being quite stressful. Just to give a bit more context, in hospital settings, it's a transcriptionist who will dictate a letter, and so we often have loads of errors in those letters that we have to correct as consultants anyway. So I can see why it is a little bit different in a hospital setting, not just because of the enclosed governance structure, but a time-saving aspect also being a little bit different. There are lots of rheumatologists actually already using this, and we get questions all the time about whether we should be using it, whether we should be deploying it. So really interesting to hear your views on it.
So I think that writing a letter is based on information that you have already recorded is a potential huge time saver. I think I'll give you examples of where patients request letters from GPs. I usually try and dissuade patients from getting them because they're not usually worth very much. It's just this is what is said in the record. But I think, then it's just, if you can design the model to just use a very closed piece of information, it's very, very unlikely to, it should still be checked, but it's very, very unlikely to produce anything that's harmfully inaccurate out of that. So I definitely think this is why it's about finding the sweet spot.